PiP stands for pee and pot. That's what a pee and pot looks like, a PiP. It's basically a biodegradable device made of cellulose and bamboo for the collection of urine, specifically for urine testing. I think we do a lot of things in the NHS with devices that aren't designed for the job that we're doing them with. So this is one of the examples where we've tried to improve what we actually use to do the test. So we all know MSU is a very common test. You can see there's certain design features about it. If anyone wants to see a PiP, I've got some with me. So this is the problem that we identified. MSU testing, so MSU, midstream urine collection, we're all familiar with it, especially you. Very important test clinically. The commonest cause of sepsis in the NHS is urosepsis. Very common test, and the key to it is a midstream urine sample currently. The sample needs to be collected appropriately, and your whole targeted and prompt treatment is dependent on the MSU. I went around 28 wards about 12 years ago and asked people what they were doing. I presume I generally got what they actually were doing rather than the answer I wanted to hear. But generally people were doing things in all sorts of different ways. Some people using foil pots, some people using grey pulp. One ward was using a reusable plastic jug, washing it out. So I heard it all, and that's in a hospital with, in an environment where we have good control. So goodness knows what's going on in the community. So inconsistency of practice, also, what is the pathway? It's done by HCAs mainly, but overseen in the training done by more senior nurses. The practice is time consuming. It's a poor patient experience. It's something we're all going to do. I suspect everyone will have to give a urine test or be involved with one of their children giving a urine test. And it's generally a bad experience. People may get urine on themselves, just to talk about it. The sample can be contaminated, et cetera, et cetera. So it's a poor patient experience generally, and it's an inefficient one for the people involved in doing it. If you send a sample and it's contaminated, all that effort for nothing, you won't get an answer. That affects clinical care. The other thing that stood out was at our practice, and I'm talking about Somerset mainly here, it was very unsustainable. We used a series of plastic objects, bits and bobs, as I was saying earlier, foil pots, things and that. But it was unsustainable. There was lots of bits and pieces that probably didn't need to be used, inefficient and unsustainable. So this sort of illustrates the gold standard pathway that everyone thought we needed to do, and this I think fits with the Royal Marsden's handbook, as I understand it, talking to Tracey and her colleagues. So in the top, you would collect the urine in a sterile plastic container, single use, single wrapped. That would then get into and Taunton into a 30 ml tube, if you were going to send it for an MSU. That would whisk its way to the lab, where someone was spending 3 to 4 hours a day taking urine out of the 30 ml tube, carefully putting it into a 10 ml tube, and they were using a pipette to do that. And then that would go on the machine. So you immediately think, well, what's all that in the middle there for? So what we do now in Somerset, in the community hospitals across our 2 sites, the standard of care, if you want to do an MSU, the patient is given a PiP, a pee in a pot. They pee in it. The tube, if you're going to send it, goes onto the little funnel. That's not a handle. At the end is a little funnel. And that then goes into the correct tube. That now goes to the lab and goes straight on the automated system. There's no one decanting, fiddling around with it, relabeling it, etc. So that's the new pathway. That's what we had before. So when we first did this on one of the surgical wards, that went well. I then presented it at a bigger audience, and IPC were there, including Tracey, and they said, this has got to stop. You are using something. Sorry, hang on a second. You are using something that's non-sterile. That's not acceptable practice. And I said, well, people were already around the hospital using non-sterile containers to collect urine in. And this is an improvement. At least it's clean and all the rest of it. No, this is fine. We support you, and we want to find out more. I think it's a great idea, but we're not going to allow it to continue in the hospital until there is good evidence that this is safe. So that was, at the same time as stopping something, they came along to make sure that if we did continue, it was going to be done in a safe way for our patients, number one. So what we did is we managed to get a grant, an SBRI grant for about 90,000 to do a study to look at the equivalence of the pee in pot in collecting urine for MSU. So the hypothesis was that the PiP would be the same. We also had some evidence that had been done on this material called thermofiber or white pulp, that it didn't shed particles. It was quite good in terms of non-microbiological contamination. So the study we set up involved about 1,500 patients, of which with paired samples. Okay, so a good group of patients from all different parts: ED, surgical assessment, frailty unit, a lot from antenatal. There's a lot of testing there, but it wasn't from one particular demographic. There were no children in the study. So we had 1,350 paired samples. They went to the lab. All underwent microscopy. 808 were cultured. So this is a forest plot. These are the results. So the medical statistician took the results from the database, and this basically is saying all the data for these organisms is all plotted around the zero. The difference there is up to 1%. The lab said if they did the same sample twice, they'd expect a deviation of up to 2.5%. So we're well within the differences you'd expect within a lab. So the bottom line is there for the medical statistician is we've shown equivalence with the PiP, a clean pulp, white pulp container with a sterile plastic bowl. The other secondary outcomes were microscopy. So before you send a sample, culture it, they look at it for red cells, they look at it for particulars, they do other things. Once again, this is all huddling around the zero. So they also support, from a statistical and evidence point of view, equivalence between the PiP and a sterile plastic single-use bowl. So clearly, I talked about sustainability. So the other thing we really wanted to test in this study was the sustainability claims we could make on the PiP. All these things, all the plastic products we use, all the thermofiber, all the pulp products we use are all made in China. They are not made in Europe even. So it all comes from China. The bottom line we found was when the analysis was done, and the analysis was done by someone who the lead sustainability fellow for GERF, so get it right first time, not me, someone who's interested and knows the methodology of cradle-to-grave analysis, looked at the two pathways, and the bottom line was, in the best case scenario for the PiP, it produced about 60 grams of carbon, including production, container ship, not getting stuck in the Straits of Hormuz, coming through, and the common pathway using the plastic things that we were using was around 500 grams. So there are different, depends slightly what you do, but there's a very significant reduction, 200 to 300 grams on each MSU. So what does that mean? If I drive my Polo for 3 miles, that's about 300 grams. So it's about 2 to 3 grams miles of travel every time you do an MSU in terms of reducing the CO2. So not insignificant on such a common test. So the bottom line, you can't have a conversation about anything unless it's going to be cost neutral or save money. So for us, once again, this is Somerset. We did the analysis. So the PiP with the 10 ml tube that goes straight onto the analyzer was costing about 32 pence. When you looked at the other one, it was about 39 pence with a plastic bowl. So we were saving some money there, or cost neutral. The bigger savings really are there's some savings in not burning plastic, for example, as well. But the bigger savings probably are in the lab technician time, because there's now someone spending 4 hours doing something else. And that adds up over the year, and they're probably pleased to be doing something else. And the HCAs were adamant it made their lives easier. It was quicker. Measuring that is very, very difficult. So we came up with 20 seconds. I suspect it could be more than that, but it certainly doesn't take longer. So it is cost neutral or potentially savings. In terms of incineration, we in Somerset can burn a ton of plastic for 50 quid. It is really, that isn't going to drive change. It shouldn't be 50 quid. It should be a lot more. That's delivered, taken away and burnt. It's madness. But that's the current situation. We also don't pay carbon tax in the NHS. We can burn carbon, we can shove it in the atmosphere, and we don't have to pay a penny for that. That will change, I hope. So where are we at the moment? Well, the PiP is the standard of care for collecting urine for MSU in Somerset. in the hospitals and in the community hospitals. It's now being trialled in 3 GP surgeries and in a care home. 45 trusts have gone online and bought some, looked at it or whatever. So it's sort of kind of out there. We've got a paper that's, from the evidence I've shown you, that's now been, well, published 4 weeks ago in the BMJ Open. So that's really great. I mean, you can look at the evidence for its safety and its carbon savings. It's out there. It's in peer-reviewed publication now. We've been very well supported by supply chain. NHS supply chain have been fantastic. They really talk the talk. No, they walk the walk. Sorry. They walk the walk. They really have been much more proactive than pretty well every other organisation I've come across in the NHS. They've supported the PiP quite heavily. NHS Green have been lovely, but they haven't actually gone out and promoted it in any way as such. But they have been very supportive. So once again, I think it's really important to note that the nurses have led this. They've run with it. They've gone out onto the wards. So we've got some from day case. We've got Tracey in the middle, who should be up here. We've got Olga as well from the surgical assessment unit. They've made it happen. They've been very rigorous. They've been involved in the training. They've made it happen. It's been fantastic. I think they've enjoyed it. They smile for the photo anyway. So NHS supply chain, it's there, you know, so that's good. It's kite marked. It's a medical device. It's fine. NHS supply chain have done their own case study on it. This is their take on the PiP, not mine. So that's sort of a third party sort of comment upon it and what they think's good about it. That's the website. I think the website's got lots of information if anyone was interested in implementing it. It's got lots of educational stuff, videos, and just all the kind of the data and links. So that's actually quite a good website.